We need to understand this concept by first understanding the timeline of events that the GI tract develops. The fetal stomach appears by 9 to 10 weeks, beautifully seen on transvaginal. Though the peristalsis is seen, starts by 11, we don't actually start seeing it in the later gestation. Fetal swallowing starts by 16 weeks, and you can see the esophagus by a radionormal anomaly scan. Meconium starts accumulating in large bowel by the 20 weeks because that's where the absorption takes place, and it fills the colon completely till term, and the evacuation can happen in the late third trimester. So when you're looking at the fetus in the first trimester during the NT and LB sang, we see two cystic structures which actually are seen in each and every fetus, the stomach and the UB. You've got to see them. But make sure that you see the stomach on either side of the diaphragm, the heart and the stomach on either side of the diaphragm. If you document that once, it's good because you know hernias can come up later, and this is a good image to have when you have any contention of having a confusion later on. You look at the abdominal wall and you look at the cord insertion. So the stomach is almost seen in every fetus by 11 weeks, but you got to understand that the physiological herniation of small bowel loops happens through the umbilicus, which is seen till 12 weeks. If it is seen beyond 12 weeks, we do consider it pathological, and especially if it doesn't contain small bowel. If it contains liver, at any point in time, it is pathological. And if you measure the height of the herniated contents, if it is more than 7 millimeter at any given point, it is again points to an abnormal pathology, namely omphalocele, because you will see the sac, amniotic covered sac with the umbilical cord inserting on to the defect and the herniated contents. In the second and the third trimester, well, you can see the esophagus behind the heart there. You see it as 5 parallel echoes. You look at the descending aorta first in the coronal plane, and then you just move the transducer slowly anteriorly. As the aorta disappears, you see this 5 multi-layered structure, and that is the esophagus, the collapsed esophagus, which is seen as you lose the aorta and come anteriorly in the coronal plane. So that's where you look for the esophagus behind the heart, anterior to the spine, and you will see the collapsed esophagus as 5 parallel linear echoes. So in the concerns fetal abdomen, apart from the GIT, you also have to look at other structures, namely the gallbladder, the bowel, the small and the large, and of course the situs. Situs, though we know the formula, I personally believe that if you can imagine yourself as a fetus, it helps identify the situs in a much accurate way. The stomach is located in the left upper abdomen below the diaphragm. That's a normal location, seen always beyond 11-12 weeks, should be identified in routine scan. If you don't identify the stomach, if you don't see it, make the patient wait, see it again, call the patient back till you're convinced that there is an absent stomach or it can fill up much later, because it's a dynamic structure, and whenever you feel that there is an enlargement, an apparent enlargement, do know that there is a nomogram which is available. Because it's a dynamic structure, it can contract, it can distend with the fetal swallowing, and the fluctuations are therefore expected. Moreover, because it's an asymmetric organ, standardization of landmarks for measurement is not simple, and therefore we use gastric area ratios and the size nomograms to see whether the fetus is above the 95th percentile or really small. So you have nomograms available, but the gastric area ratio actually is fairly more accurate, which calculates the gastric area ratio to the ratio of fetal abdominal circumference, and the normal ratio is between 0.05 to 0.15. But the thing that goes with the stomach is the liquor, because you know when you go more distally, the fluid gets absorbed, and the chances of polyhydramnios decrease as the obstruction is more distal. Whereas the obstruction is more proximal, there's more chance of a polyamnios because it leads to impaired swallowing or impaired absorption of fluid. So it all depends on the amount of liquor. So if you do not see the stomach, or if you're seeing a very small stomach, but if you have a normal liquor, then it's probable that the stomach has just emptied. So make the patient wait for some time. When the fetus swallows, you can see the stomach filling coming in. So what I generally do is, if I need to confirm the status of the stomach, I wait, or I actually follow the fetal swallowing. So I go to the fetal mouth, see the swallowing movement, and try and follow the swallowing movement to see whether the liquor goes into the stomach. The other time when it is seen is when it's actually in the thorax, and is a form of congenital diaphragmatic hernia. Well, if it's an absent liquor, the first thing that you want to rule out is, of course, a PROM and bilateral renal agenesis or severe form of fetal growth restriction. Whereas if you see polyhydramnios, then you're worried, because that means you're dealing with probably proximal obstructions like esophageal or duodenal atresias, and esophageal atresias, and you're dealing with cleft lip or cleft palate or gross CNS anomalies, which leads to impaired swallowing. And that's one of the reasons why you have polyamnios. So a large stomach or a small stomach, just if you have the nomograms, you depend on the quantity of liquor, you can base your diagnosis. And when you see a persistent non-visualized stomach with gross polyamnios, you're fairly sure that there has to be a proximal obstruction. The small bowel is located centrally and is always seen as an echogenic structure. You can start seeing peristalsis by 18 weeks. The diameter cutoff is generally 7 mm and lesser, so you will always have a small bowel which will have a normal peristalsis with a smaller diameter. Though the jejunum is located in the left and the ileum to the right, we cannot differentiate that in a fetus. The small bowel is a small bowel which is centrally placed with loss of haustra and a normal peristalsis, which is seen very well in each and every fetus, provided you look for it. The large bowel is more tubular and it is more peripheral. So it is identified by 22 weeks and it should be imaged beyond 28 weeks. The appearance of the large bowel changes over a period of gestational age because of the accumulation of the meconium. The appearance of the large bowel is largely because of the appearance of the meconium. So at 24 weeks, it appears like tubular cystic. At 30, you will see internal echoes. At 36 weeks, you will appreciate the hostrations, and you will have it more echogenic towards term or towards postdatism. So it can even reach a diameter of 20 millimeters at term. So this is what you need to know. It's more peripheral and it has to have hostrations. So how do you measure where do you measure the large bowel? The descending colon is measured as a maximum internal diameter. The cutoff of colon at term is 18 millimeters, whereas the fetal rectum is measured as a maximum AP diameter, and the cutoff at rectum is 13 millimeters. So you do have cutoff values at 95th percentile. At term and at gestation, you can just follow the nomograms and you will know whether you're dealing with an abnormal bowel or dilatation bowel. So the difference is stark. You cannot ever confuse, provided you know the anatomy. The small bowel is centrally placed, is more echogenic, will show peristalsis and will never have haustria, whereas the large bowel is peripheral. It is tubular, it doesn't show peristalsis. The appearance changes from hypoechoic initially to more and more echogenic as it comes towards term, and towards term you will always find the hostrations very well. Well, do remember that your fetal bowel analysis is not complete without actually demonstrating or identifying the perianal muscular complex. It is formed by the puber rectalis, the internal and external sphincters. It helps in diagnosing anorectal anomalies, and therefore this is important, especially when you have a dilated bowel, when you have a lot of mixed cystic structure, if you have a bicystic structure in the lower pelvis, if you have a sacrum which is cut off, then you need to look at the perianal muscular complex, and it is seen as a target sign where you have a hypoechoic peripheral ring and a central echogenic mucosa. So this has to be identified beyond late, though it can be identified 17 weeks, but it's not always, but you can definitely see it in the late second trimester and always in the third trimester. And that's the same view In the sag section where you have the anus and you have the anal canal and the rectum seen behind the urinary bladder in this sagittal view. You see this hypoechoic with debris going right up to the anal canal in a sagittal section. So coming to anomalies and starting from proximal, you have the esophageal atrasias where you have persistent either non-visualization or a persistent small sized stomach associated with polyamnios. You can have the dilated blind ending proximal pouch, but that is not always seen, mind you. It is seen in almost 40% of the cases. There are 5 known types, 90% of them are associated with distal tracheoesophageal fistulas. And this is what makes the diagnosis tricky, because the stomach may not always be absent or completely absent all the time. We know that it is associated with karyotype abnormalities, and there could be associated cardiovascular and bacterial anomalies. But yes, when you see it, that's the diagnostic sign to have the upper esophageal pouch, where it is a blind ending pouch which fills with, this video is not running. So you see the upper esophageal pouch, which is seen to distend with peristalsis, and notice the contraction that you see. It is not going below the upper mediastinum, it stops in the upper mediastinum, it changes in dimension. There is active peristalsis happening, reverse peristalsis happening, and that's very convincing of an upper esophageal pouch. As said, we have 5 types. 86% of the times you will have the proximal esophagus, which is completely cut off, and you have a tracheoesophageal fistula with the trachea communicating with the distal end of the esophagus. The positive predictive value of esophageal and TOF is just 30 to 70, and the reasons is that 85% of this are associated with fistulas, and therefore you can have fluid seeping from the fistula into the stomach. So the stomach may not always be absent. There could be some amount of fluid which is seeping from the trachea into the stomach through the distal communication, and therefore this is something that is tricky, and the upper esophageal pouch may not always be seen. See, the reason we cannot generally pick up an upper esophageal pouch at 18 weeks when we do a normal anomaly scan is because it's a blind pouch. So there has to be, sufficient strength in the swallowing to allow the fetus to distend a collapsed pouch, and therefore this strength later, it comes much later in the second trimester, and that's when the swallowing has enough strength to distend an upper esophageal pouch which is otherwise collapsed, and therefore the pickup of an upper esophageal pouch increases with passage of time. You may or may not see it in the early gestation, but that's the reason why you may not see it early on, and as the strength of swallowing increases, the fetus can have that strength to dilate collapsed upper esophageal pouch. The stomach may not line the abdomen, and the left-sided hernias, you can see the stomach as well as the small bowel, which is displaced into the chest, and you can prognosticate this by using the LHR and the observed to expected LHR ratios. Duodenal atresia is a classical sign, is a double bubble sign associated with polyamnios in the late second trimester. The double esophageal, the double bubble sign is the dilated duodenum communicating with the dilated stomach through the dilated pylorus. So it's mainly seen after 24 weeks, and you have to understand that there was a strong association. Almost 50% of these cases are associated with Down syndrome. But the characteristic hallmark is the duodenum, the dilated duodenum has to communicate with the stomach through the pylorus. It has to be located in an appropriate location just right across the midline. If you do not find a communication, you have to think of other differentials like a choledochal cyst. So the communication with the stomach getting established is a must to say that this is a duodenal atresia. 70% of these patients have associated anomalies. It is a part of 23 syndromes. 50% association with Down syndrome, and therefore you need the detailed scanning to exclude other anomalies. You need amniocentesis and appropriate counseling. However, you can see double bubble later up in the third trimester with normal liquor. In those cases, you can think of other causes of duodenal obstruction like Webb, Ladd's band, annual pancreas, and stenosis. Atresias of the intestine are generally vascular accidents, and therefore they generally involve the jejunum and the ileal loops. You have a dilatation of multiple or a dilatation of single loop, the diameter which is exceeding 7 millimeters with increased peristalsis, late onset polyamnios, but the dilated bowel is central, and this is what is important to differentiate it from a colon, that it shows peristalsis, there's no hostrations, and it is centrally located. Dilated bowel can rupture and lead to meconium peritonitis. You can have echogenic small bowel as a result of meconium peritonitis. You can have an enlarged stomach if the obstruction is more proximal. So do remember that the more proximal the obstruction, the more association with the karyotype abnormality. The more distal the association, the less association with the chromosomal abnormality. But at the same time, more proximal the obstruction, more association with polyamnios. The more distal the obstruction, the lesser the chances of polyamnios. But when the dilated bowel ruptures, it leads to a sterile chemical peritonitis where you have foreign body and giant cells and calcium which get deposited in the inflamed tissue and leads to calcification almost about 8 days after perforation. When it concerns, meconium peritonitis, you also have to consider the possibility of cystic fibrosis, especially if you don't see the gallbladder. You have that meconium plug syndrome where you have increased viscosity of the mucus leading to an obstruction in the narrowest portion of the small bowel, and that's the IC junction. That's where the meconium plug gets stuck, and that leads to dilatation and eventual rupture. So when you have a cystic fibrosis, 86% of this time, you will have a rupture and intra-abdominal calcifications. And depending on whether they are focal, they can be scattered throughout the peritoneum, or they can be seen underlying the surface of the liver. You can have associated abnormalities. When you see meconium peritonitis, you have to have fetal ascites, polyamnios, dilated bowel loops, and if it is more contained with a better prognosis, you will have a meconium pseudosis. So you can have dilated loops, which is worrisome. You can have ascites, you can have polyamnios, but a good positive outcome is when you have a pseudosis, which is a localized perforation which gets localized by it, and eventually, if you do not have any other associated features, if you do not have dilated bowel, if you do not have too much of ascites, it is in fact has a better prognosis. So the prognostication actually depends on the site size, location, calcifications, but most importantly, still the presence of dilated bowel, ascites, and polyamnios. So if you have to differentiate jejunal and ileal, it's simple, it's radiological. We all radiologists know that, dilatation of loops will be more marked when it is more proximal. So you have jejunal atresia, there will be more dilatation, lesser chance of ascites, but polyamnios will be frequent and associated anomalies, as I said. More proximal the obstruction, more chances of polyamnios, and more the chances of chromosomal abnormalities. Ileal, on the other hand, has more common chance of rupture and perforation, but a rarer chance of having a polyamnios, and even rarer chance to have an associated abnormality. So when you have an intestinal atresia, an obstruction, you try and first exclude other associated abnormalities. Know that the more distal the obstruction, the less likely the chance of a chromosomal abnormality, but do follow these patients up for serial scans. And you have to see it in view of increasing bowel diameter as a bad prognostic sign. You look at whether there's a growth restriction, look at the polyamnios and complications like meconium peritonitis and so on. So volvulus intussusception and malrotation basically have non-specific findings. You can have whirlpool appearance or target-like appearance within the small bowel. So that's a very old video where you can actually see the whirlpool sign within the centrally located small bowel, where you see there is a classical whirlpooling happening in the center of the fetal abdomen, and the very classical midgut rotation. Well, echogenic bowel is a non-specific marker which can be seen in normal feti. So when you see an echogenic bowel, the first thing you would want to ask the patient is, did she have a first trimester bleed? Because intraamniotic bleed, getting swallowed, the blood can change its echogenicity over a period of time, and that's the first thing we would like to rule out before we move to more sinister causes like infections and cystic fibrosis. So there is a subjective grading system for the echogenic bowel. So what you need to do is reduce the 2D gain, turn off harmonics, use a lower frequency transducer, and then you compare the echogenicity of the bowel to the adjacent ileum. So depending on the echogenicity, if it is less than the ileum, it is grade 1, equal to the ileum is grade 2, and more echogenic is grade 3. Of course, the more sinister ones are the grade 2 and the grade 3. So first exclude an intraamniotic bleed and history of intraamniotic bleed before you move out to more sinister complications like aneuploidy, cystic fibrosis, infections, and obstruction and meconium peritonitis. Well, large bowel abnormalities are less likely to be diagnosed and are even rare. You have the uroseptal malformation sequences, and you have the persistent cloaca where you will have a bicystic structure, and because of chemical mixing, you will have a lot of echogenic things in the fetal abdomen. Well, imperforate anus is when you actually see an absent perianal muscular complex, and you will have an associated dilatation of the bowel loops and calcified intraluminal meconium peritonitis. So knowing that the colon is distended, you have a definite markers to say that the colon is indeed distended and more echogenic. So you just have to know that you follow a certain guideline and look at it as a composite picture. I'm including gallbladder here because when you have a dilated bowel or when you have an echogenic bowel, do look at the gallbladder, because an absent gallbladder is often a sign that you're dealing with a cystic fibrosis, or you can also have an associated aneuploidy. Well, as I said, you look at the composite picture. You could have an hepatosplenomegaly in fetal infections, and when you have an echogenic bowel and you have an associated liver or spleen which is enlarged, you again have pointing or pointers towards infection. So all in all, looking at bowel is easy, differentiating them is easier, but knowing that the obstruction is proximal or distal makes a huge impact to counseling, because the more proximal the obstruction, you need to counsel them about genetics. The more distal the obstruction, we know that the association with genetics anomalies is lesser, but then we need to follow them up for worsening prognostic markers like persistent dilatation or development of meconium peritonitis. Thank you so very much.